So this gives you a sense of the agenda for the day. Um, it was very much a full day, and we had some wonderful keynote presentations from HCA staff and Project Echo and our esteemed colleagues at the Primary Care Council. And I think there was a lot of interest in Project Echo. Many people were not familiar with it and its resources, and a definite expressed interest in having Project Echo partner with the primary care payment reform going forward. And we are doing so. And we had, in addition to those wonderful keynote addresses, we had 2 rounds of 3 breakout sessions each. And in the interest of time, I'm not going to read off all those to you, but really trying to give people the opportunity to learn about all aspects of the program and whom we're partnering with, and to hear from practices that have done some innovative things. And speaking of innovative things, we had a panel of practices talk about their quality improvement efforts, and that was certainly very well received. And we're grateful to Dr. Andazola and Dr. Wangler for their presentations that wrapped up the day. And many people said that would have been a great kickoff to the day. Either way, their talks were wonderful, and we're very much appreciative of this. And the last slide I'll share. Next slide, please. Is just some photos to give you a sense of the vibrance and participation in the exhibit hall. So we're definitely planning to do a similar kind of event next winter, February, March, whenever that is held. And we're hoping for an even bigger exhibit hall, again, to offer information about the resources that can support practices. And at this point, I'll hand it off to Janine.
Thank you, Craig. All right, we can go to the next slide. So I'm going to give you an update on where we are with quality measure selection, and we can go to the next slide. So as I'm sure you're aware, the PCPR program is in alignment with, but differs from, value-based contracting that the MCOs execute with individual providers. These are both very important initiatives that work together to support HCA's overall quality strategy. But there are some unique considerations in both. And as a statewide aligned coordinated program, the PCPR VBP program is dependent on the selection of performance measures. So that's what we're going to focus on today. And those are performance measures that all participating providers will be evaluated on going forward. So this is a really key component of the way that this VBP program has been initially executed as a state-directed payment. We can go to the next slide. So just a review of that payment arrangement. The VBP program is funded through a combination of general funds allocation, and it's executed through a managed Medicaid state-directed payment arrangement. And that's how the federal share of the Medicaid dollar is received. There are different types of state-directed payment programs, and the initial version of this program is a uniform percentage increase. So that means that there is a percentage increase for all participating providers that is the same for each payment period that is applied to all eligible primary care claims. And the performance measure requirements for this phase of the program are based on data submission for a number of measures and meeting requirements for structural measures. Was there a question, Dr. Wangler? Did you want to ask a question?
Yeah, thanks, Jane. Just backing up to the previous slide for a second, I just had a question. Is there, I mean, I think that it is challenging that there is the, sort of state VBP and then the MCOs have different contracts with different requirements and different expectations. Does the state in their contracting with the MCOs have, a say in that? Is that something we should be thinking about or advocating for as better alignment or not having two separate processes for VBP?
So we could talk about this for a really long time, and maybe this is something that we could take as an after action item. I think it's a great thing to bring up. It's a great conversation to have. I would say, in the interest of time, so generally it's aligning to that overall quality strategy, right? And making sure that the performance measures in this program and all of the requirements for a state-directed payment are met. The MCOs are also focused on that quality strategy and the measures that are selected as part of that quality strategy. And so we are paying attention to alignment between those two initiatives. There will always be some degree of variation because of kind of the rules of the game in both of those. And I think that's an area that we could explore further and discuss. Tristan, is there anything else you'd like to add at this point to that?
No, as usual, you covered it well.
Great point. So currently we know, and this is anticipated to continue, right? That we have a lot of variation in primary care practices or participating providers as they're defined in the state-directed payment program. So that involves, the number of locations they have, the geographic distribution, the service mix, the kinds of care that they're providing, the different populations that they're serving. Medicaid claims volume varies, and states of readiness vary. And so these are some of the factors that are absolutely critical to consider as we move forward with program design and measure selection. So this is going to be a recurring theme as we go forward. We'll go to the next slide. So where we want to move this program is called a value-based payment or a VBP type of state-directed payment. And I know that these terms are used in multiple ways, so it can get confusing. So the actual title includes VBP, value-based payment program, but there is a specific state-directed payment type. And the requirements for the current type, the uniform increase, and the value-based payment type are slightly different. And that's really around the methodology for assessing quality performance on performance measures, how you relate performance to payment, and what those performance measures actually are, the nature of those performance measures. So in order to evolve this program to a VBP type, we need to have performance measures that are actually quality measures, clinical and utilization measures, where performance is being evaluated based on performance on those measures. We also need to develop that assessment methodology and how we will link performance to payment and a payment calculation methodology that is different from a uniform increase. And then the component of ongoing evaluation of the program, of course. You can go to the next slide. There are many, many, many considerations in operationalizing a VBP program of this type. They're all listed here. You can think of this kind of as a checklist. And many of these things are interdependent on each other. But what we're going to center on now and the focus of our discussion today is about the quality measurement strategy. And that's what we're focused on in this phase of the program as we try to evolve this to a VBP program, because measure selection and alignment and feasibility and reliability of calculating those measures and using them for performance is absolutely critical to the VBP program type. And that's what we're very focused on today. So successfully operationalizing a VBP program type will depend on aligning policy, data, payment methodologies, and the operations of implementing these performance measures so that we can continue to get CMS approval for this program and meet ongoing renewal requirements. You can go to the next slide. In our work with VBP programs, we have found that measure strategy and measurement science is one of the areas that is often underestimated when a program is initially visioned, and it becomes really the largest operational challenge. We've worked through some of those challenges and other programs in New Mexico even. So we want to focus today on some of the key areas that we're looking at and how we're going about the feasibility assessment. Go to the next slide. I think it's very helpful when we think about a measurement strategy. We have to have this zoom in, zoom out perspective. We zoom out to the state level and we look at how does performance across all of the providers look, especially in environments where there are those variations in practice characteristics, right? And in the Medicaid population differences. And then when we zoom in on individual provider performance, we have to keep in mind that broader context of what's trying to be achieved. But we don't want to misinterpret performance patterns that may be driven by systemic factors versus provider level behaviors. And these differences often come out in the very granular details of performance measures. So for program design, we have to consider this bidirectional dynamic so that we don't introduce bias into the program and the way providers are measured. And that payments are distributed. Our goal is to have fair and equitable payment assessment and payment in this program and in any VBP program. We can go to the next slide. So there are a set of principles that we follow for quality measure selection. These are some of the most important ones with some really important examples. So obviously we have to have compliance with federal and state regulatory requirements. In order to continue to secure the funding through state-directed payments, we have to meet CMS requirements. Those requirements over the last few years have become increasingly stringent. It began in May of 2024 with a final rule that made explicit some of the requirements that must be met for these programs. And over the last couple of years, we've seen an increased level of scrutiny in the approval of the programs. So keeping those things in mind, we design so that we can meet requirements. Aligning with the goals that you all have to reform primary care in the state, and that the state has for the Medicaid program has to be considered within the context of the model design. And what are the core functions of primary care? And what are appropriate performance measure areas for primary care providers that fit into that model? Data feasibility and validity is one of the foundational areas that we need to consider. It is somewhat easy to agree on areas that should be measured and even specific measures that we would like to be included in a program. But if you don't have the data needed accessible in order to calculate those measures, it's a non-starter, right? So we need to, when we assess feasibility, we need to look at what is the available data? Is it complete? Is it accurate and reliable? And what does that look like when we try to actually calculate the measures? And we've already talked about variation in provider characteristics. What about variation in performance? When we look at actually calculating measures and looking at how providers are performing on those measures to establish baselines and benchmarks, we sometimes see things that we didn't expect. When we try to do that. So that's another piece of the puzzle. We always want to try to aim for simplicity over complexity and reducing any administrative burden. We like to say just because something's possible doesn't mean it's a good idea to do it or do it at least right now. So we look at all these factors when we're assessing feasibility. And then assignment and attribution. How are primary care providers assigned members? Because these are specific measures that we're going to be looking at and introducing going forward that are event or member patient driven. So you have to have a connection between that patient and the primary care provider they're assigned to or attributed to, who actually provided care for that patient that gets them into the numerator and denominator selection. We also have to look at things like using nationally recognized specifications or creating state-defined measures that are aligned with those, and not selecting measures where there's no realistic ability to improve performance in the aggregate. We call that topped out, right? So these are all things that we keep in mind as we go through a very stepwise feasibility assessment. You can go to the next slide. The key question that we're trying to answer in this feasibility assessment is, are the envisioned measures viable, considering the variability we have in provider characteristics, the current state of data availability, the feasibility of calculation, and the current state of readiness. And that includes providers' ability to influence outcomes on the measures. Okay, so let's go to the next. So this is the set of measures that we have been working on and continue to work on feasibility assessment. We've also looked at adding additional measures to the feasibility assessment, but this is the set that you have seen that was preliminarily selected for the next phase of the program. So I won't go through all of these because I know you've seen these before, but this is the primary set that we're evaluating, and then we're looking at additional options as well. One of the things we had determined before getting to this measure set is that although there was a desire to look at some other clinical measures, those measures required clinical data from the EHR, and the state of data readiness was just not where it would need to be in order to be able to calculate those measures. So the measures that are being evaluated currently for the next phase are only those where we can access administrative or claims encounter data to calculate them. We can go to the next slide. And why this matters so much in VBP programs is because, oh, I think we skipped a slide. There should have been one in between the two that maybe we're missing. It looks like we lost
the small denominator
somehow.
one?
Yeah, so let me just talk through that. I'll talk through an example. If we have two practices, practice A is a relatively small practice, and we're calculating a measure where we capture 10 eligible patients in the denominator. And then the numerator, we capture 8 patients. That's a performance rate of 80%. Okay? Practice B is a very large practice. So they have 1,000 eligible patients in their denominator. 800 of them meet the numerator criteria. So that's also an 80% performance rate. So one might think at first glance, that's identical performance, right? But then what happens if we change just one patient outcome? So practice A, the smaller practice, has only 7 in their numerator. Now we have a rate of 70%. Practice B has 1 less patient in their numerator. So we have 799 out of 1,000. That's a 79.9% performance rate. Almost statistically significant, not significant from 80%, right? So for the small practice, we have 10 less percentage points. For the larger practice, we have 0.1 less percentage points. So we look at denominator sizes with a high level of scrutiny because the smaller the denominator, the more each individual patient disproportionately impacts performance. And for some of these measures, we are finding very small denominator sizes. We can go to the next slide. Generally speaking, minimum denominator sizes for most measures is at least 30 to have reliability. We like to see 150 or greater for risk-adjusted measures and utilization measures. And so when we have less than that, we have to make some choices about whether or not that measure can be used that measure can be used for all providers or another whole host of decisions that come from that. And this is because we need to be sure that we're not introducing this distortion. We're tying payments to performance in a VBP program. So we want to be really sure that we're measuring in a valid and reliable way. And we want to make sure that we're looking for signal, not noise. Go to the next slide. I know we're up on our time here. So just want to give you an update in terms of where we are now with this assessment. So we do know that there's some variability. There's a lot of variability in provider characteristics. We've had some challenges identified with the data availability. Those have led us to where we are now. So we are still undergoing this analysis. We anticipate doing it for the next several weeks. And we know there are some challenges that we're going to need to solve for. But the good news is there are solutions for those challenges. There are best practice approaches and methodologies that we can consider to achieve what we believe are the shared desired outcomes, and that glide paths are always possible. So we can't calculate measures today from a practical standpoint for using clinical data because that data isn't available, but we can create a glide path to that for future phases of the program. We can select measures today that are valid and reliable to evaluate performance and then evolve that over time. So that is the process we're going through now to provide the analysis and the evaluation to guide decision making. And we can go to the next slide and we'll show you kind of what that looks like in a timeline. So we're currently doing that feasibility assessment. We need to finalize the set of performance measures for 2027, as well as the assessment methodology and payment methodology for the next calendar year in September, because the CMS preprint needs to be submitted in October for next year's program. That's the approval package to CMS. And then the next phase of the program, of course, begins in January of next year. And then the intention there is to continue this process, right? We're on a glide path to ensure that we are all rowing in the same direction, that we have accountability for outcomes and fair and balanced rewards for providers, especially as they take on increased risk, and continuing that alignment with other initiatives and programs within the state. Questions? Matthew, I see you have your hand raised.
I was hovering, but I guess auto AI probably clicked the clicker. I was pondering. I was going to wait for you to finish first. I just want to circle back to where we started in Val's point, you know, for us in the front line. So I'm in a school-based health center today, and I love that I saw the measure of comprehensive well exams got picked because, you know, we got to do that with our DOH contracts already, right? And so there's not a duplicated effort. And then I understand all the micro details of how you get there. And is it claims based or is it this or that? And empanelment, I know you used a different word, but how important that is, you know, all of that. And I'm sure I saw Yvette and I know there's other FQHC representatives here too, but, you know, and then you have UDS measures, you know, completely different data set and how those things get captured. And I think just over all the years of being at one time a chief quality officer and being involved in these types of plans, it all comes down to that. The buy-in from us as the primary care workforce in accomplishing these is it's got to make sense and it can't be duplicative. And then the buy-in of the patients, right? Because the patients are like, I'm here for a sore throat. Why are you doing SBIRT or whatever the thing is, right? And so I think just ways, you know, I'm sure it's been at the forefront all along. I just want to echo that. I think I speak not just on behalf of the workforce on the front line, but also on behalf of the patients on the front line that, you know, thank you for your efforts of making sure in the end it will all make sense and be of true value. Thank you.
Thank you so much for those comments. And, you know, not the focus today, but there's another whole conversation to be had about how we support achievement on the outcomes that these measures look at, right? And how we can do that in an aligned way. And that's part of this program too. and that's coming. And that's what we need to focus on going forward as well. So thank you. Appreciate the comment. Any other comments or questions? Sorry, I went over the allotted time.
Just one more plug. If you liked hearing about this, if you liked giving input on this or thinking about it, my email's in the chat. So please let us know if you want to join the VBP program stakeholder work group.
And that's where more specific and detailed information will be reviewed as we have the results of the evaluation and the next decision making phases need to take place. So,
Yes.
thank you.
Awesome. A big thanks to our PCP VBPR program. It is a tongue twister. Yeah, so I realized we're a bit running over time, and so in the interest of covering everything today, I wanted to post to the group if we would like to continue working through our scheduled break, or if anyone needs to step away for a break, please feel free to do so. But if everyone agrees, we can just take a 5-minute pause.
I think we
Right.
keep going and people can step out if they need.
Yeah, we can do that. It looks like
Thanks very much.
wonderful. All right, we will move on to our next presenter, Keenan Ryan.
Sorry, give me 1 second. My camera was not turning on. All right, good morning. For those that haven't met me, my name is Keenan Ryan. I am our Director of Pharmacy and Acting Chief Medical Officer, while our current Chief Medical Officer leads the whole Medicaid agency. So I'm happy to be here and to be able to give some updates. It's always great to come back. Before working for the state, I was our pharmacist representative on the PCC, so definitely fun to always come back to this meeting. Next slide, please. All right. This first thing is we're trying to spread the news far and wide, and we're trying to make sure everyone's aware of it. So there is a federal rule that requires not only the billing entity for Medicaid, but also the person who ordered the service, often known as the ordering or rendering provider, to be enrolled in Medicaid as well. So, the best example is you write a prescription for a medication, but it might get filled at a pharmacy that you have no association with. Well, the pharmacy can't get paid and the member can't get the medication unless you are enrolled in Medicaid. We've had guidance that this needs to happen, but given the current federal landscape, we're increasing our enforcement on this measure. So starting July 1st, if the ordering and rendering provider is not enrolled in Medicaid, the prescription or the x-ray or the lab will deny. We already had edits in place to deny if the billing entity was not enrolled in Medicaid. So oftentimes physicians are potentially enrolled because if they want to bill for their own service, they'd be enrolled, but they may not be. And so it's really important that all providers get enrolled if they're seeing Medicaid patients. This includes federal programs that sometimes have slightly different rules. Still, if they're going to see a Medicaid patient, they need to be enrolled as well. So if you want to check on your enrollment, go to this yesnm.gov, as well as get updates on this through the link that's at the bottom related to ORP. Dr. Andazola, I see your hands up.
Yes, Keenan, I have a quick question.
Sure.
In residency programs, are the residents enrolled? Because I have found that some pharmacies will fill a resident's prescription, some pharmacies won't. Some hospitals will honor an order for a mammogram, some won't. And so how does that work? Because we have 30 plus residents with hundreds of orders a week. And we can talk offline. I know that may not be part of this, but
no,
that's
curious. A great question. This was actually an area we have started tackling and reaching out to the residency program. So I'd love to connect with you on this. We will enroll them. So I kind of did a landscape analysis across the nation of what's going on here for residents. This is a sticky issue for a lot of states because they're not fully independently licensed yet, but they are definitely writing orders. And so we made the decision it's the safest case to enroll them, and we'll enroll them as a general physician, and we have some special requirements for how they submit that documentation. Happy to work with your credentialer or who's ever going to be helping your residents enroll to make sure we meet that. So if you want to email me, I'm happy to connect you with our provider enrollment group to do that.
Excellent. Thank
But
you very much.
great question.
Yeah, thank you.
Any other questions on ordering and rendering providers? Charles?
Yes, sir. Is the ultimate goal, because I've seen this in the past, where Medicaid attempts to have only the PCP assigned to be able to give them medicine? I'm very concerned about that, but I can see how this may continue down that slide.
Yeah, that is in no way in our plan or view right now. This is truly just to make sure we're following federal guidance that all people providing care for individuals are enrolled in Medicaid. So we're not going to such an attributed model at this time.
Great, thank you.
Yep. Brian, go ahead.
So a quick question. I mean, and you know, what happens when a member is receiving care out of state, you know, from a facility or pharmacy, and we have pretty severe issues in getting them to enroll with Medicaid now. I mean, how would
Yeah.
we work around that? I mean, it's a perpetual challenge from an MCO perspective, you know, because, you know, the further a member or the further away that a facility is, the less likely that they want to do any of this, if that makes sense. So I don't know if there's a way to collaborate,
Yeah,
support, but that's a major challenge.
Totally appreciate it, what you're saying. I think for us, there are challenges for this. The example I often use is, let's say a member takes a trip and they sprain their ankle on vacation in Indiana and they go see an urgent care. We really need to find a way to make sure that that care is covered. And we're working on that. That said, the border towns, which I know are historically hard to get individuals to register, and that's basically any service that's provided within 100 miles of the state border, we treat as an in-state provider, essentially, almost as a border town. I understand their perspective that they're in Texas and they want to register in Texas Medicaid and don't need to register in ours. However, the volume of claims in some of these border towns is the same as it is in Albuquerque. So, for example, if El Paso has the same volume or a very significant volume, maybe not the same as Las Cruces, why would El Paso be exempted from the rules if they're within 100 miles and seeing a large volume of members? I know that's a rub. I know that's hard to do, and we need to work on it. And I'm happy to be the voice of calling, you know, someone's really giving you a hard time registering. I'm happy to be the state person that has to make a call to someone to say, we really need you to register, or you won't get paid, right? Like that's the thing. You won't get paid, or your member won't receive access to care.
I completely agree from the kind of the border areas that a lot of times, yeah, the volume, but I guess my concern from a, you know, again, from an MCO perspective is when these members have to get care, you know, they're way out of state, you know, that they're going to California or they're going, you know, because we can't deliver it. And a lot of these facilities just will not, you know, even with direct engagement from myself and others, you know, we can't force them. And so, but at the same time, we're caught in this trap that the member needs care.
Sure.
So and maybe we can talk about it more offline, but it's just one that is you know, it's a daily problem for me. And I know for my colleagues at the other plans.
Yeah, I get it. Those are hard because to the institution, you're talking 1 or 2 patients a year. They may not want to register. I get that. And so let's have a conversation offline if we can come up with a cut point or a value that makes sense.
Great, thank you.
But I think the message today, especially for the PCC, is spread the word that they need to get registered. That it's coming, and yesnm.gov is a great way to make sure you're enrolled, everything's there, and we can go forward from there. Next slide, please. All right, I know I've talked to you all about our preferred drug list in the past. I just want to give an update. We had our turquoise claim system that went live 2 weeks ago, 2.5 weeks ago. And we're in a good space, I would say, with it. I don't want to jinx anything, but so far we're making our way through the small glitches we found and moving in the right direction. That said, because turquoise claims got delayed out until the last week of March, we did not feel it was appropriate to start our preferred drug list the following week. That felt like a recipe for disaster if things didn't take off the way they have so far. So we're pushing to July 1st. It aligns with our fiscal year. And our MCO partners are already aware of this. But so the preferred drug list is, as we talked about, a unified list of medications. In the initial periods, the MCOs will still have utilization criteria control, meaning it won't be completely aligned for everything, but at least the preferred versus non-preferred to start with will be. During the first 6 months, just to make sure it does not cause a lot of member abrasion, we'll be in a soft period. So we'll say we prefer these. We'll start putting messaging as time goes on saying this is not a preferred medication. However, the member won't get denied at the start. So, really trying to give a soft glide path until we get to this preferred drug list overall. Let me stop there and take any questions. Charles, go ahead.
Yes, as a primary care provider, I like that soft period, but I was wondering if you're going to have a process by which that list is easily accessible by all of the different providers. I know they don't have to do anything or read anything, but maybe an email or something that they have simple access to that list so that they can start working on it. It takes a lot of time, in my opinion, to find these lists, which is the current list, so on and so
Yep.
forth. So if you can keep that in mind, I'd appreciate it.
Yeah, absolutely. I hear everything you're saying. We will have it up. There is some question about how early do you post it where it starts causing change before the list is completely live. I appreciate that. We're also trying to come up with some innovative strategies to get you the list of orders, meaning can I actually give you a list of each member you have that's on a non-preferred agent? And then you can evaluate, do I need to submit a PA? Do they already have a PA, or do we need to consider switching? And across MCOs, this is something we're trying to work through, so I don't want to commit that 100% be available and ready and easy. But this is the solution we're really trying to work to make it the lowest burden on our providers to get there. So I hear what you're saying, and definitely look out for more updates from us.
Thank you.
Yvette.
Hi, I'm not sure how this interfaces with what you're working on, but certainly for a bunch of different providers who are on this call, we have the 340B program, and we are, it's really important for us to get the discounted pharmaceuticals, and we also use the margin capture on that for uninsured folks. So we certainly have parameters around what our drug formulary will be. And so we just want to have some of that conversation before things are said and done.
Yeah, great question. So we set a list of what we think should be preferred and not preferred. The current market capture with everything we've already done is about 80 to 90%. A lot of these things, blood pressure is like 90% generics, if not more, right? We follow those generics as it is. For 340B, if you use 340B stock, we still won't claim our rebates on our side, and that's the standard rule, as we've always done it. As long as the 340B claim is clearly identified to us, we don't claim our rebate. So we still defer to you for claiming the rebate first. As far as the preferred drug list is, though, we don't what's available in 340B stock is a little bit of a changing pattern as time goes on. And so we don't make the decision based off of what's available 340B or not. We try and make the decision on what's best available for members in the state. So short answer is you can still claim all rebates you have on your claims, but we don't necessarily make a 340B determination on what we should or shouldn't.
I
Sorry?
think there's a little nuance there. So like, absolutely, there's no margin on Medicaid. So I don't know. I just wanted to put it on the table. I think
Yeah.
it just requires a little more thought and discussion. That's all.
Sure, absolutely. I get that fee-for-service Medicaid is at actual acquisition costs, and happy to set up a meeting offline if you want to discuss the nuances more.
That'd be great. Thank you.
Mhm. All right, any other questions? Putting my email in the chat, and I don't multitask well, so give me 1 second.
Keenan, this is Ruby, and quick question. What does CMD stand for?
Oh, yes. So we use a contractor called Conduent, and they have different platforms for different types of claim systems. So the Conduent Medicare system is CMS, which also could be confused for the Center of Medicare and Medicaid, right? The Conduent Medicaid is the M lowercase ds. So it just stands for Conduent Medicaid System, but it's our new claim system.
Thank you.
Mm-hmm. Any other questions? All right, next slide, please. This is something that I think we may have presented in the past, but it's kind of come under new management and really started to take off. I wanted to make sure it's aware to all of you in case you ever have questions. We have a clinical benefit review committee. The best way to say this is imagine it's a P&T committee, but not for pharmacy, right? So we look at the clinical benefit of different services that could be provided under Medicaid. And so we look to see if we should approve something with prior authorization, maybe not add it because the data is just not that supportive of its use. This committee is now run by the Center for Health Policy from the University of New Mexico, and they actually do the evaluation on each individual intervention for us, which is great. The committee is staffed by clinical staff from a variety of different divisions within New Mexico state government. So Medicaid, the Behavioral Health and Service Division, DOH, OSI, all have members on the committee that sit and provide their clinical expertise of the agents that are being looked at. And so, for example, we had a request to cover topical oxygen for wounds, percutaneous electrical nerve field stimulation for irritable bowel syndrome, and Gozellix, which is a new gallium for cancer, specifically prostate cancer prognosis and diagnosis. And it was really a great discussion where they reviewed the literature, talked about the potential benefit or lack of benefit from these different instances, and provided some, just purely clinical review of the agent. From there, it goes to Medicaid to see having that clinical information. If we can cover it in our existing budget, we would need to ask for additional budget in the next legislative cycle, etc. That being said, if there's a new or existing therapy you want to see if we cover or we should expand coverage, feel free to send an email to the email listed below. I think it's a great opportunity to really improve our oversight on our judicious use of what we do and don't cover for things. What questions are there? All right, hearing none, I think I have one more slide. All right, now that these are officially signed, I think it's worth covering some of the bills that we'll be keeping an eye on as session goes on, this may not be every act, but at least one that Matt is watching, even though we may not have specific interventions that Medicaid has to do. So the first one is there's an increased coverage for wheelchairs and activity chairs. This is an expansion so that individuals don't either get a wheelchair or an activity chair. It increases access and coverage for that. There's a loan repayment, which is obviously important. We don't have a direct role in that, but anything that improves our provider networks improves care for Medicaid. So we're always very interested in that. The repeal of 2025 laws on vaccination. This can be a confusing bill if you try and read it, but really it removes some of the sunset provisions that were put in during the special session towards some of the vaccine rules we had changed. So those rules will now continue forward, as the emphasis is that there really is no change. We're removing the sunset provision of that. So the state will still have access to make decisions about vaccines and which vaccines to purchase, not being directly tied only to specific government recommendations. There's Senate Bill 20, which is a prior authorization act. This really has two pieces to it. One is it creates a definition for serious mental illness, and it prevents prior auth or step therapy provisions for serious mental illness outside of medical necessity. So MCO could say, do you have this condition? Yes or no, but beyond that, that's where the PA really stops. In addition, there's also for chronic medications, there's no PAs allowed for 3 years. So once you have that first PA done, that PA life is now for 3 years instead of 1 year. One, I know that it's really near and dear to our Medicaid director's heart, is this pediatric palliative care benefit. This is a new benefit we're looking to start. I would say that there's still several steps that have to go through this, since it was a Senate and House memorial. We have to go through LFC and a little bit more operational steps to make it work, but we're starting that process to build out a palliative care benefit. Senate Bill 101 is something that actually impacts how we pay hospitals and what we use through our current hospital payment system. This bill had a sunset provision on it as well, and this just removed the sunset provision so that we can keep doing it until the federal government tells us we can't. There was a couple other bills, House Bill 34, Senate Bill 1, and HB 50 that all look to increase licensing changes and licensing compacts to add towards our provider network and capabilities. I will say that Senate Bill 1 is one we needed for our rural healthcare delivery fund, a rural healthcare transformation, excuse me, or federal grant. There's still 3 more we need in the next legislative session, or we're at risk of clawback of money. So something we want to give you that information to advocate for. We still need physician assistants, psychologists, and emergency medical EMTs compacts. Otherwise, CMS could potentially try and come back after money. We don't know how likely that is, but it is a real, it's clearly written in that federal grant that they could do that. And then the last one is there was some decreased reporting requirements for induced abortions, just as more of a patient privacy and protections portion to make sure that that data is not getting shared, especially as we look at places that border the state that might have different laws around this. So just trying to maximize our patients' protection and privacy. Let me stop there and see if there's any questions. Hearing none. Yes,
Tina,
go ahead.
it's Ruby, and I had a quick question. So you had said EMTs, PAs, and what was the third?
Psychologists.
Okay, thank you.
Right. Well, I appreciate you all for listening to me talk. If there's any questions, I put my email in the chat. Happy to discuss any of the updates that we covered today. So thank you.
Thank you, Keenan. Thank you for taking the time to share all these updates and insights. We really appreciate your continued leadership in really helping strengthen primary care across New Mexico. Next, we're gonna move on to the 2026 legislative session. We're gonna hear from Elisa Reed and Amy Alexander. So, Elisa, I will pass it on to you.
Hi, everybody. Nice to see familiar faces and new faces alike here at the PCC meeting. I'm Elisa Reed. I'm the acting rural health director here at the Healthcare Authority. Formerly was helping with the primary care council work. So happy to see the robust conversation and work happening here. So thanks for inviting me. Today, I just want to provide a really high level, what we accomplished during the legislative session with workforce and coverage and affordability, and then give you kind of the latest and greatest updates on the rural health delivery and rural health transformation programs. And I think we also have Amy here, who is leading the rural health delivery fund work now. So next slide. All right, so we were able to achieve quite a few of the things that we wanted to, especially around compacts that are also linked with our rural health transformation work. So we did see that the legislature made some updates and changes to our medical malpractice, so establishing those tiered caps, and it'll be interesting to see over time how that impacts medical malpractice insurance rates. So we're keeping a close eye on that and looking forward to seeing some outcomes from that new bill. Higher Education Major Projects Fund, so UNM received $150 million for a new School of Medicine. So really diving more into workforce expansion projects and being able to build that workforce. And the interstate licensure compacts, the state is trying, or HCA is trying to get 5 total compacts across the line. And in this session, we were able to get physicians and social worker compacts passed. So still some more work to do in the 27 legislative session, but happy to see a couple of those pass. Next slide. Okay, so I won't read through all of these, but HCA was able to get the Healthcare Delivery and Access Act, providing some additional funding for hospitals during this time, passed. House Bill 4 for more revenue for the Healthcare Affordability Fund, and House Bill 306, so around hospital or patient facility fees. So we also were able to really get a robust budget for the Healthcare Authority that will help us achieve our mission, vision, and goals, and being able to care, for New Mexicans and help support our service delivery operations and capacity here at HCA. So all in all, I think it was a short 30-day session. It was successful for us. Still a lot of work to do though, coming in this next legislative session. Next slide. Right, so the Healthcare Delivery Fund, just a quick update on that. I just adore this program. It's so great, and I'm so happy that we've been able to get more funding over the years. We have served over 127,000 individuals because of this funding, which is absolutely amazing, and it keeps going. So our first cohort of applicants, they're about to wrap up their programs at the end of June. And so we're really excited that they've been able to establish new service lines, have new patient care models. So we're really excited about those. If you want to know more, learn more about what folks have been able to do, you can go to the HCA website. We'll pop that up on the chat here in a second. We also have a stabilization grant through Healthcare Delivery Fund that's open right now. So that closes April 19th. That funding is really intended for truly stabilization of our healthcare system in this very volatile time. So if you feel like your clinic, hospital, someone that could really benefit from some stabilization grant money to really help make sure that doors stay open, service lines continue, that funding's available, and you can apply through the 19th. Hi, Yvette. Hi, friend. How are you? Do you have a question?
I do have a quick question for you, Elisa. It's great to see you back. You've done all kinds of other things, and it's really great to see you here. One of the things, so we've been talking with our folks about the stabilization funds that were passed last October, because we really think this is targeted towards, existing safety net providers, where a lot of the previous stuff was new and expansion stuff. But one of the aspects of it is asking for a sustainability plan. And we would love to get some more information or guidance. And so it's taken us a while to hear from our folks as to like where you are in the process. But one of the sticking points seems to be the sustainability plan. And I don't know if you have any insight, any thoughts about that. I know it wasn't necessarily something that was required of the previous cohorts. And we sure would like some more information about what you want to see there, because it's hard to sustain primary care in some of these areas, especially now. So we'd love to hear more about that.
Yeah. Amy, if you want to talk about kind of where people can access more information and then how to ask questions, if you want to pop on for a second.
Yeah, sure. Hi, Yvette. So I dropped in the chat our website that has the full RFA listed there. So that'll explain a little bit more about the whole stabilization piece and what we're looking for in more detail. I also included my email. Any specific questions can be directed towards me, and I'm definitely willing to help answer any questions that people may have.
Fantastic. Thank you so much.
Yeah.
Whatever we can do to help make sure people can have successful applications, we want to do that. So, just let us know what you need. Absolutely. All right, next slide, please. And this gets us into the Rural Health Transformation Program. For those of you who aren't aware what this is, it is a project established through the federal government, where all states had the opportunity to apply for money to help transform rural healthcare in their state. And so New Mexico applied and was awarded just about $1 billion over the next 5 years. We were the top 13 state as far as the amount of funding that we received. So our application was very successful. We did a really great job there. But now it's time for us to really do a great job implementing and working with our rural communities to really accomplish what was set out. So just so you all know, we did do some stakeholder engagement prior to our application. So we did collect ideas, thoughts from our rural healthcare providers and communities on what should go in this plan. And from that, we were able to come up with these 5 that you can see on the right-hand side initiatives. Really everything from expanded care to building, retaining our workforce, really having some innovative, opportunities for innovative ideas from rural providers and communities, providing technical assistance and services to help with what Yvette was just talking about, those sustainability issues that are really challenging for folks. And then really having some robust technology and data and analytics for folks. So I'm really excited to be leading this work at HCA, and we are truly just at the beginning stages. I just found out last week that our budget is now unrestricted from CMS, meaning we can start the process of, yay, thanks for, it's huge. So the process of really establishing some RFPs, RFAs, having stakeholder conversations. So I've been working really hard to get our plans together, get some calendars together. We're working on a website to make sure everyone stays informed. I will also pop in the chat here in a minute, a forum we put together for folks who want to stay engaged, get our emails, get communication, who, those of you who want to really be notified when things are coming out. I'll pop that in. So if you could just fill out that form for us, that would be great. And you can also, I'll stick my email in as well, and you can reach out to me directly, and I'm happy to answer questions as I have more information. Hi, Maggie. I see your hand up. You're on mute if you're talking. Okay. Maggie, reach out to me if because we can't hear you. So reach out to me if you have a question.
Hey, Lisa, it's Ruby Ann. Good to see you.
Hi, Ruby Ann. Good to see you too. We just emailed yesterday.
Yes, about some of this stuff. So yeah. Two questions really quickly. Could you explain just a little bit more what you mean by you just found out the budget was unrestricted? Sure. And then secondly, could you say a little bit more about the Rural Health Data Hub? Thanks.
Sure. So we were awarded for the first federal fiscal year, we were awarded $211 million. Before we could start using that money, we had to go through a process of budget negotiations and approval from CMS. So that involved really making sure that they understood and that our plans for spend were in line with what CMS would approve us to do. We had just some very minor changes that they were requiring from us. And so we were able to get those items back to CMS so that they would take the restriction off. So we were not able to do any spending up until about a week ago. Maggie, I think you're off mute now.
Yes, I have. Do you have a release date for the call for the rural transformation grants?
Sure, that's a really good question. So we will start releasing RFPs and RFAs between the end of April and middle of May. So very, very soon. We will also start some stakeholder engagement. We are going to be building an advisory council. We'll have an application process for that, similar to how we built this primary care council, where people can apply to be on that advisory council. So that'll be launched soon as well. Hi, Val, do you have a question? Nice to see you.
Lisa, you as well. Thank you so much. And sorry if I missed this, but are you anticipating like 5 RFA, like a separate RFA for each initiative?
There will be more than one scope of work on some of these initiatives. So some of the initiatives are very large and complex. So there may be more than one award under each of the RFPs or RFAs that we submit. So for instance, the Health Innovation Fund, that'll be fairly similar to how we've done the Rural Health Delivery Fund, where we will go out for RFA. We'll ask rural communities and providers to provide their ideas and budgets to us. And then we'll do a vetting process and a selection process for that. Some of these other things, like for Healthy Horizons, we'll be establishing health hubs. And so those are opportunities for larger health systems to apply for like a regional approach to service delivery. So the amount of work that is under the health transformation is really broad and wide. And so it's going to take lots of different partners and lots of different entities to really be successful in establishing all of the ideas that are in this plan. Does that help answer the question?
Absolutely. That's very helpful. Thank you.
Yeah. Hi, Matt. I just talked to you as well the other day. How are you?
I'm good, partner. So yeah, and just a little, I think just a couple things. I don't know that there's so much questions, but I think things on people's minds here. So there's a lot of misinformation out there. How it got out, I don't know, but it was like, oh, that's money for the rural hospitals. And just to clarify, what this money, I'm not saying rural hospitals aren't going to get any of this funding. I'm just saying that there's a much broader scope than that, right? And, to me, again, number two, and Semillas de Salud, the Rooted in New Mexico, call it what you want, everything from K to 12 pathways to, all kinds of stuff. Charlie, what you put in earlier, social determinants of health, so much, there's so much in here. And so if you go to the website also, you'll see the detailed application. I think it's 80 some pages long, right? It's very detailed in terms of what this could potentially, what this opportunity can potentially be. And so I think that's one thing. And then, we know Elisa's in a leadership role and a service leadership role for this very important project. And we also know her history of working with us as a primary care council, that, in that second desired community impact, when you look at that and you go down to the third part where it says communities design, communities, not the healthcare authority, not some, agency, communities design and implement programs that address their most pressing health needs. So again, this relationship between primary care and our gente, our people of New Mexico, making sure that they'll get a say, and what these programs could potentially be, and transformation. That word, rural health transformation. To me, that word is as big as revolutionizing primary care. Back to this council and what this should be. This could be big, a huge opportunity. So to me, it's very exciting. And those are the pieces that I've learned along the way here that hopefully get us all excited as this opportunity unfolds.
Thanks, Matt. And thanks for saying that. Yeah, I don't have all the answers, certainly. My job is just to really facilitate this money, this opportunity that we have in New Mexico, and make sure that I get the right people at the table and the right voices and the right the people that really know what's needed in rural health, in rural communities. So just know that we have a structure here to really make that transformation reality, and that we will work closely with our rural partners, and really the work's going to be led by our rural voices and rural communities. So thanks for lifting that up, Matt. I really appreciate it. All right, and I did see one question about being able to help individual providers. Yes, so this program should touch everyone from the elementary student who wants to be a healthcare provider in the future, to our small independent practices, to our larger rural hospital systems. So that, like Matt was referring to, it's really, really comprehensive. And in my opinion, is very, I was not part of the application process, but I'm diving more and more into it, and it's very comprehensive. And I'm really excited about the work that's coming. So thanks, everyone. I'll make sure that link to the contact list is put in here in a moment in my email. So yeah, some key takeaways here. I won't read through these. I know you all are running a little behind schedule, so feel free to go on to the next topic, but so nice to see you all. Thank you.
Thank you, Lisa, for that thorough update, and for all the amazing work that you're doing here, and tracking these developments. We're going to move on next to our next presenter from the Mexico Department of Health.
Hi, I think that's us. I don't see those slide up yet, but we're presenting on the New Mexico Communications Hub, or Chili Chat. Oh, there it is. So I'm Alyssa Luisi, and I'm here with my colleague Jessica Carr. We're two members of the Chili Chat team at the DOH. Thanks so much for having us back to share about our progress and developing this initiative. And we're going to try to condense our presentation since I know we're running a little bit short on time. So let me see if I can skip ahead to slide 4 and just give a bit of a recap of the goals of this initiative and where we are in the development process. And then I'll turn it over to Jessica to share a bit about how we're going to pilot this platform. So Chili Chat is an initiative that was developed to consolidate communication across DOH offices and programs that support the same provider populations or working on joint initiatives. And we are really wanting to ensure accessibility to reach a wide breadth of providers to connect them to each other, as well as to DOH. And hopefully HCA as well, many of whom may not currently be connected to each other or may be unaware of established DOH channels. So thus, we're creating an online community platform, which has been named Chili Chat. And we're exploring lots of different opportunities for how this platform can support the expansion of the healthcare workforce through networking, how it can serve as a channel for peer support, and promote geographically specific social care networks as well. For example, Find Help, as well as facilitating access to public health data. Next slide. And so here are some of the current challenges that we've identified throughout the past year of speaking with providers as well as program managers at DOH and HCA. We've identified that providers often have difficulty finding each other if they're not exactly working in the same area, the same specialty. And so we're hoping to help link primary and behavioral health providers to each other, as well as to program resources at the state level. We're also hoping to address information silos, so the issues of resources being scattered across multiple platforms or difficulty finding resources on existing websites, for example, the DOH website, and difficulty connecting with particular staff members who are involved in particular provider-facing programs. And then we are also looking to disrupt the norm of static communication. So right now we have a lack of real-time two-way communication channels between providers and state agencies. And Chili Chat, this community that we're building, will facilitate ongoing discussion both among providers and with DOH and other agencies, staff, and peers. The platform that we will use to build out Chili Chat, which is going to be built on a software called HiveBright, has the ability to create different community groups that house resources in community media centers, as well as discussion forums. And so we can use those to connect peers through those interest-based groups to foster support and collaborative learning, as well as facilitating access to those important resources. So let's see, I think we'll skip ahead to slide 8, if that's possible, and talk a bit about our pilot testing process. So that's that champion engagement slide. And I'll turn it over to Jessica to do that. Oh, you're on mute. Sorry, Jessica.
Hi. I think it's the next slide after this. We can skip this part. Okay, next slide. Next slide. Okay, so we're running a pilot beginning next month and through the summer. So if you're interested in getting on the platform and playing around, or if you want to participate and do the testing and be more involved, then please take a shot of this QR code and sign up for the pilot, and we'll get in touch and give you the keys to the Chili Chat platform. And maybe we can speak again next month and talk about more details of the system we're creating. Next slide. This is our team. And so if you want to get in touch, this is Alyssa and my email address. We'll also put a video in the chat so that you can learn more. And I'll put our email addresses in the chat as well, since we're almost at 11 o'clock. But thank you so much for giving us your time. And I think that's it.
And you can also reach out to Dr. Anjali Taneja. She was the original visioner for this project, and she's now a member of our team as well. And she's a member of the PCC Equity Work Group. So she'd be really happy to share more about this project and her ideas for how it can align with the Equity Work Group goals as well. She wasn't able to be on today. She's traveling back to New Mexico, but I'll give her the shout out in case you want to connect with her as well. Thanks so much.
Thank you, Alyssa and Jessica. Really informative. I will share your slides and the video in an announcement with the larger group. Thank you. All right, so we're going to move on to PCC's next steps and closing comments. Right, so as next steps, we're going to continue to build on many of the initiatives discussed today. Stay aligned on some of these legislative updates and support the rollout of ongoing projects like the Rural Healthcare Delivery Fund, Rural Health Transformation Program. So your engagement and collaboration will be key to our success here at HCA and across the state of New Mexico. So again, thank you all for your continued service. I want to see if there's any comments from anyone from voting members, advisory, or just anyone in general. Opening the floor before we close today's meeting. Nope. All right. Our next meeting is going to be July 9th. You all should have it on your calendar. If not, feel free to reach out. Yeah, this was great. Thank you all.
Thank you.
Thank you. Bye.
Thank you.
Does anyone have any last minute comments or questions? Maggie, Wendy, Jason, or Dr. Shelton, any comments?